Do you have any questions from our last conversation? Yes.
When there, real quick, the graph that you showed of how much each state.
Yes, the Medicaid table.
Yeah.
Mm-hmm.
So then I should have written this down. Another graph where it was how much they make. Is there like a way that they formulate like how much the doctor makes based off of like how much?
So each state, see the problem, and we'll talk about this, but why don't we talk about it now? So each state in the Medicaid program, and at the moment I think only Arizona is not at all in Medicaid. So we have 49 other states that participate in Medicaid. And remember, Medicaid is a federal-state collaboration, and the amount of money that the states get is partly based on how much money they put up to match. So if you want to put up, like I said, for Ohio, 30 cents, the federal government will give Ohio 70 cents to make the dollar, all right? And then the other issue that exists, so you've got all different amounts going to the different states for Medicaid programs. And then the next issue is, well, how much are we going to pay for our pool of providers? So remember, they have to have pediatrics, family practice, internal medicine, and OBGYN. Those are the 4 core services that all states have to have in order to participate in Medicaid. So then the next challenge is, what are we going to pay our providers, our physicians? And they start with the Medicare schedule that's developed every year, and that's a federal schedule. So that comes out of Baltimore, Maryland, CMS. So they start there, and then typically what the states do is they whack it way down. So in Ohio, for instance, the Medicare speech-language evaluation under some of the codes I'm going to be mentioning in a couple minutes, the Medicare, I think it's around $132, something like that for Medicare. But in Ohio, it's $64. All right? And again, there are these actuaries who sit in rooms and come up with how much of whatever there is, how many pediatric visits are there in Ohio for kids on Medicaid. Right? So they have that. They can capture those numbers, and they then determine, well, we've got so much money for this service, and so we have these many units of service typically, and they take generally a 3-year average, and then they come up with what they're going to pay the doctor for a pediatric checkup. All right? So there is science behind it. It's not numbers that they pull out of the sky, but there's just a lot of pressure on all states right now to try to keep their Medicaid expenses under control, because it takes so much of state budgets. All right, so all of us pay our taxes, and some of that money goes to Columbus and is used to create the match for the Medicaid program. Now, you're aware that there was a lot of turmoil once the Affordable Care Act, Obamacare, was passed and approved and approved and approved, that there was a lot of pressure in certain states not to expand Medicaid and make it available to more people. And so we still have several states in the country who have just a basic Medicaid plan. So anyway, if there are other questions, I will answer them. So today we're going to focus entirely, almost, on reimbursement and then improving access to services. Okay, and again, I'd encourage you to ask questions as we're going along so that they are in the flow of the conversation. So basically, we have 2 payer types in reimbursement, in payments. One is the public payer. So Medicare, Medicaid, and some others that I'll mention in a second are public payers. That means that their monies come from taxes. All right, so everyone pays income tax to the federal government, and that money, part of it, is used for public health care services. Then you have the private payers, and the private payers are for-profit companies like Aetna, Blue Cross Blue Shield, Cigna, et cetera, United Healthcare. And every month we pay a premium to that company, whatever it is. Typically, the younger you are, the lower your premium. The older you are, the higher your premium. And so the third group is self-funded. So some people pay their own insurance out of their own pocket, and they don't contract with Aetna or whoever. So let's talk about the public payers first. So the Social Security Act was something that was generated in the 1930s by President Roosevelt. And you have to look at that act as if it was a series of chapters in a book. But in that book, they call them titles and not chapters. So under the Social Security Act book, there's Title V, which was originally called the Crippled Children's Act. Yes, we wouldn't say that today, but in fact, that's how they looked at it back in 1935. And so today it's called the Bureau of Children with Medical Handicaps, and we here at Cleveland Hearing and Speech Center and other providers have kids who come to us and are covered by that act. It typically covered kids with cerebral palsy, kids with cleft lip and palate, kids with certain permanent disabilities. Then it was Title 18, the next chapter that applies to us, and that's Medicare. So that's a huge component of the Social Security Act. And Medicare was passed in 1965 under President Johnson, and there were three components to it. Part A and Part B are primarily inpatient and outpatient. So some of our services are covered under Part A, some of our services are covered under Part B. And then in 2005, I think it was, we added a prescription drug benefit under the Bush administration. All right? All these other things are the hyper detail of the Medicare program. So prospective payment system is how Medicare and providers interact. Now, Medicare does not go through the state and then to the hospital. It goes right to the hospital. All right, so that's an important, very important distinction between Medicare, Medicaid, and some other titles. Diagnostically related groups. Okay, so DRGs were created under President Reagan's administration. And what DRGs did is, if you're admitted to the hospital with a diagnosis of stroke, CVA, all right, they've got all this data that tells them a stroke should cost about this much to manage in the hospital under Part A. That's DRG, diagnostically related groups. And so they, the hospitals get a sort of benefit. We'll say it's $5,000 for stroke admission. So if they provide the care for $4,000, they get to keep that extra $1,000, the hospital does. But if the patient costs $6,000 or $7,000, they lose that money. Medicare doesn't give them more money, all right? And so that's been a real problem because obviously there's an incentive to provide less care to get the sort of incentive bonus money. Get it? And what you then have to track is readmission rate. So if you discharge a patient too early, like someone who has a swallowing disorder, and you discharge them too early and they develop a pneumonia, aspiration pneumonia or something like that, then they have to be readmitted. So it costs more money. So there's this arm wrestling match between providing the care under the DRG limit and at the same time not going over the limit and costing more money. And then resource-based relative value scales, something I was talking a little bit about last week, but it's how we set fees using RBRVS and then this other thing that goes to the Resource Utilization Committee of the American Medical Association. So it's 10 after and you guys are still looking, like eyes open, and it's hopeful. So I wanted to just show you the new codes that took, again, a tremendous amount of time through the Healthcare Economics Committee of the ASHA. We used to have one diagnostic code, 92506, And it was useful, except that it was very limited, and it didn't give us a whole lot of different information. So over the span of, I think, about 5 or 6 years, we finally got the coding folks to allow us to subdivide 506 into these 4 more distinctive codes. So speech fluency is 92521, 522 is speech production, 523 is speech production with language assessment, and 524 is voice. Yes?
And these are all assessment or diagnostic codes, right?
Yeah. So, but there are others. These are the more common ones that we use. And typically in our business, upstairs, downstairs, wherever, we do 92522 and 92523 the most. And then third would probably be fluency, and last would be voice. We don't do a lot of kids or adults here at Cleveland Hearing and Speech Center that have voice issues. All right, so let's keep moving on. So the next chapter is Title 19, and that's the Medicaid chapter of the Social Security Act. And, you know, basically it was targeted to folks with low income and folks with permanent conditions. All right, that was really the issue. And under the Medicaid Act, when states try to wiggle out of not covering speech pathology and audiology services, we can remind them that under the EPSDT section of the Medicaid relationship, they have to provide our services. So you just go, excuse me, you know, this allows you to cover us, or requires. And so it requires reimbursement for children. And then in Ohio, we have a concept called Healthy Start, logical notion that the sooner we can get to children who have whatever problems, typically the better the outcome is when we treat them. All right? So then Title 20 was kind of what they called a wastebasket category. It was for like what's not covered by Title 5, Title 18, Title 19. Oh, let's do this one, Title 20. It'll be our social services title, and we can put certain things in there. But it's very mushy, and over the past 20 years, it's kind of disappeared in terms of its use. The next big one was Title 21. So Title 21, the Children's Health Insurance Program called CHIP, or in some states S-CHIP, state CHIP, S-CHIP, was meant to get to more kids, all right? And it was launched in Congress by Senator Kennedy from Massachusetts and Senator Nancy Kassebaum from Kansas. And they worked together really hard to get S-CHIP passed in 1997. And what it did is going back to that table, that Medicaid table I showed you that looks sort of like a crazy Christmas tree, you know, the number in Alabama was what, $4,400 or something, and if you make more than $4,400, you can't be on Medicaid. Well, that's the 100% level. So what S-CHIP did is it allowed children in families who make $4,400 to add another 50%, so that'd be $2,200, so $6,600, and those kids could get coverage under S-CHIP. That was the purpose. And again, the thinking is the sooner we can get to kids who have whatever kind of issue it is, for whatever reason, the results will be better. It'll be lower cost in the long run, right? It's preventive. Now, another public payer that's generated through tax revenues is the U.S. Department of Education. So the big component under Department of Ed is, of course, the Individuals with Disabilities Education Improvement Act. So they added improvement a few years ago, 2004. And under IDEA, our services are covered there too. So speech pathology, speech language pathology, audiology services are covered. Then there are various other titles inside the Education Act, like Title I, that have to do with literacy. And I won't say finally, but over the last few years, school districts in particular have started understanding the relationship between speech language acquisition and literacy acquisition. And the data is like just starkly clear. No speech and language, no literacy, period, we're done. all right? And it's helpful to us. Another important component under the Department of Education is the Bureau of Vocational Rehabilitation. And BVR, works with persons starting at age 14, or has historically, and then works to persons who roughly are 65, 66. And it's kind of mushy. It depends on the particular state. It depends then on the individual and what their issues are. But as you can tell by the title, BVR, Bureau of Vocational Rehabilitation, has to do with keeping people employed and therefore generating tax revenues for state and federal governments. So our services are covered under that too. Now recently, in the last, say, 10 years, we've had trouble in Ohio with Bureau of Vocational Rehabilitation covering hearing aids. So they don't cover them anymore. So we have to get them through other means, and we can talk about that later if we have time. Now let's shift from public payers. I just covered the big public payers. So the Bureau of Children with Medical Handicaps, the Medicare program, Medicaid program, Department of Ed, and Title 21, the S-CHIP program. So those are the biggies. There's others, and part of our job as administrators is to try to find those others that might cover our services. Because you can imagine that if you're seeing a child with a serious communication issue, and you're seeing him 2, sometimes 3 times a week, that can get expensive really fast for a family. And it's not that they don't want to provide the services to their child. They've got these 2 other kids that need whatever, all right? So now we'll shift to the private payers. And again, the private payers are financially supported by premiums that all of us pay every month, all right? And the big units there are the managed care organizations, MCOs, and the health maintenance organizations, HMOs. So you have MCOs and HMOs. And again, the issue there is making sure that our services are covered by the particular MCO or HMO. All right? Then we have fee-for-services, which are your traditional indemnity plans. Indemnity is a fancy word for managing risk. And so we all pay car insurance and life insurance and health insurance to manage our risk, to share our risk with the rest of the people in the country when it comes to healthcare, automobiles, whatever. Don't name your car Brad, right? So, very annoying commercial. Medical savings accounts, MSAs, are another way of getting our services. The issue there is that they are high deductible accounts. So for a while, my son, who's an architect, and his wife were on my son's insurance plan, and it was a medical savings account. And they had to put in personally a lot of money every year to get some health insurance. Well, now they're under his wife's plan, and that's gone away. But they're called the wealthy, healthy plans. And they're fine for people who are wealthy, who can afford the high deductible, and who are generally healthy. All right? That means low risk for an insurance company. So low risk, we won't have to pay a lot of money for this guy. Next, client out-of-pocket resources. You pay out of your own personal monies. So public payers, private payers, and then you have these various federated agencies, they're called, federated. So United Way is the big one. And then Easter Seals, United Cerebral Palsy, the Eagles, the Delta Zeta, foundations. Cleveland Hearing and Speech Center gets, geez, I will guess $300,000 a year just from foundations for covering services for kids and adults, and then individual donors. So when you look at the budget of an agency, you have the money that's generated by public payers, private payers, contracts, and then you have these entities, and this is not big money, except for maybe United Way, but Easter Seals and United Cerebral Palsy are smaller dollars. So let's now take a look at the positive aspects of managed care and health maintenance, and then in a few slides, the not so positive. All right? So this is how I sort of conceptualize managed care organizations. So you get the big brawny guys on the left side of the boat, and you got the little skinny, scraggly guys on the right side of the boat pulling the oars, and you can imagine what's going to happen. The boat's going to go in circles, but at the same time, our friend has blisters. So whatever, the point is, it's to symbolize resource allocation, which is what managed care organizations are supposed to be about. So the positives are that it causes us to focus on functional outcomes, practical improvement. All right? The insurance companies want to know very basically, what difference do you make in this person's life because of your services? What practical, everyday difference do you make? That's what they're concerned about. So it has increased accountability for clinical professionals. You know, it's compelled us to look at our practices, look at what we do. And I want to tell you, just as a sort of parenthetical comment, that speech-language pathology and audiology are light years ahead of behavioral sciences like psych and substance abuse management and those kinds of things. We've been much better able to nail down what it is we do and what the impact of that is. All right? And I think occupational therapy has done a good job. I'm sorry, physical therapy has done a good job there. OT, I'm not sure how they're doing today. The emphasis then is on preventive care and health maintenance. So keeping people healthy. So today, everyone in companies are wearing, you know, different little monitoring devices, Fitbits and whatever else, Garmin's and et cetera. And again, it's cheaper to prevent illness than to treat illness. So that's why there's this emphasis today on preventive care. And then a more judicious use of limited health care resources. So the pie is finite. There's only so many dollars in the pie, whether it's public pie or private, there's only so many dollars. And so what the insurance companies and governments are trying to do is manage those resources as well as they can. Okay? How you doing? All right. Another positive has been that it has caused organizations to operate more like businesses. All right. Now, some people like that and some people don't. You know, folks in the not-for-profit arena, some of them, don't get that it's a business. This is a business. Cleveland Hearing and Speech Center is a $4.2 million business. And if we don't make our money work, we go away and then the business stops. So we have centers in this state, most recently Toledo, that imploded because while they had a terrific executive director, they lost some United Way monies, they lost some other funding, that was it. The business collapsed. And that means that about 700 people a year in Toledo stopped receiving speech, language, and hearing services. All right? There's a real consequence. So we have to document better. We have to do research that shows that what we do creates a more informed prognosis. It creates a certain treatment efficacy, you know, question about efficacy. Is it better to see kids individually or to see them in groups? Is it better to see kids once a week, twice a week, 3 times a week? Is it better to see them in cluster type programs versus extended programs? Those are all efficacy questions. And there's also inside the therapy session what you do. And is it a waste of time or is it really getting to your goals, what you're trying to accomplish? Development of evidence-based practice. So more and more insurance companies are wising up and they are saying when you meet with them, well, show me some research that supports that this particular intervention you want to do is effective. You know, Lee Silverman, show me the data on Lee Silverman voice therapy or treatment and whether this approach is effective with people who have various neurological conditions like Parkinson's. Now the negatives. The negatives are regrettably more slides than the positives. So everyone gets managed care. Everyone gets it. They just don't want their care to be managed. All right? So when mommy and daddy bring their little Xavier to the hospital, I don't care what you do. I don't care how much it costs. Just do whatever you can do. All right? But when the doctor or the doctor's assistant says, well, this is going to cost, people get a little queasy. But at the same time, the problem in managed care, and to me, a large philosophical difference, is that it's not like buying a car. It's not like going to the car dealership and saying, well, I want this model and I want these features and blah, 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 and I only have this kind of money to pay. So healthcare is not like that, because in many cases, it has a dramatic impact on a person's quality of life or life, right? So then the next problem is a very narrow definition of medical necessity. All right, they control that definition as a way of limiting payouts. All right, reimbursement is only for evidence-based interventions. We're only going to pay for this, So we had a situation, it was a while ago, dealing with an insurance company in Cincinnati, and they wanted all this data. So this agency, working with American Speech Language Hearing Association, put together, I think we put together 5 binders of data on the effectiveness of all these different interventions. And we sent them to this company in Cincinnati to be reviewed by their medical advisory team. Never heard from them. And at the same time, they did start covering our services. That goes back to our last week's conversation about advocacy. All right, but there's a notion out there that people are trying to rip off the system, and okay? So evidence-based, very important. Difficulty getting credentialed by HMOs can take over a year. I told you that story, 18 months, 18 minutes, 18 months, 18 hours rather. Difficulty obtaining authorizations. So the more time they give permission for you to treat someone, more often, the more it costs them. So they try to limit the authorizations. And they try to find different reasons, like evidence-based, to reduce those authorizations. Restrictions on the length of service, meaning time, and restrictions on the number of visits. All right, so last week, that story, 30 visits to 70 visits with Anthem Blue Cross, 30, 70. And I don't know if I told you, when we finally saw the financial data from the insurance company, what it cost them to expand their speech language pathology benefit for preschoolers was they couldn't even see it on their printouts. It was so tiny. It had just negligible impact. But they want to know that, so it's important for us to be prepared. Reductions in reimbursement rates, I've talked about that. How much they pay per visit, per 92,507, for instance, a single therapy visit, how much they'll pay varies. And then they slow walk the payments. They make them, and that was also an issue with Toledo. Increased payment denials, and we'll talk about that if we have time on how you reverse those denials, but I can tell you the statistics are very compelling. So if you have a claim denied, whether it's personally or in your organization, if you challenge that denial, you have great odds that they will pay it. They don't want grief. Bureaucratic obstacles, already talked about that, polite word for other things. Time-consuming appeals process. So that's another way they slow walk the thing. So they deny the claim, you submit an appeal, and then it takes forever to get a response on the appeal. Use of non-rehabilitation professionals to do utilization review. This is a real, So what some insurance companies are doing is they are hiring speech pathologists as consultants to advise them on claims that are being submitted. The problem I have with that, again, is that the speech pathologist is being paid by the insurance company to help them not pay claims. Now, what we would need, it'd be a little more complicated, is a sort of third party that gets money, all the agencies, all the insurance companies kick into this third party, and then the third party hires the consultant in terms of payment. And it'd be a little more objective, it'd be a little more independent, removed from the problem. Interference and intrusion by insurance companies on clinical practice. You know, these guys don't know speech language pathology, and yet they're out there saying, well, I think you should only do 10 visits. Oh, really? Based on what? You know? Disruptions in the continuity of care goes back to the appeal. So if they deny an authorization or they slow walk an authorization, then either your agency keeps seeing the person and not getting paid, or your agency puts the person on hold until the insurance company resolves their issue. But what that creates is a disruption in care. It disrupts the continuity of care. And what we do know from school-based research is that to the extent that, you know, the summers off are great for the speech pathologists and the teachers, but we see a regression in the kids when they come back in September or late August, and we're kind of back to not square one necessarily, but they've lost, all right? They've slipped down the mountain a little bit. Restrictions in access, this is where CareSource got nailed. Restriction to access for persons with developmental disabilities, any kind of degenerative disease, ALS, multiple sclerosis, any of those conditions, or chronic conditions, say like cerebral palsy. They look for those diagnoses because a bill, when you submit a bill, there has to be a diagnostic code, and in our business, it's the F80 point whatever series. So those are the ICD-10 codes. And then there's a bunch of CPT, Common Procedure Terminology codes, CPT, that are attached to each code. So when they don't match, the computer throws out the claim and a human looks at it. All right? It's just because the volume is outrageous. You know, the volume's outrageous. And then it creates another dynamic, and that is competition between providers. So HMOs, if they're bidding on a contract, and you know, we lost a contract a few years ago with an organization here in Cleveland. Another provider came in and they underbid us. Well, we tried to say, well, you know, we're better and this is why. And you're getting what you pay for. Well, anyway, the whole thing collapsed in a while, and then they came back to us. You know, but in the meantime, the kids that were supposed to be getting served under the agreement weren't getting services, or they were getting an inferior quality of service. Consequences of increased productivity demands. So here's how it works. We'll say a speech language pathologist is making $45,000 a year as a base salary, and then there's a 20% benefit package. So, you know, insurance, all these other things, retirement, vacation, sick time, continuing education. So typically the salary is $45,000, just making up a number, and then there's a 20% benefit package. And then on top of that is usually another 18 to 20% for the office, the lights, all the stuff that's the billing people, the administrators who negotiate the contracts. So that's all in there. So when we'll say we end up with 55,000. Well, for each person, we've got to hit that 55,000. And so you divide it into, you know, how many hours can a person reasonably do in a week or day? And it's right now around 27, 28 hours. And we use that number to say what our number of units has to be to hit the target, right? It's like airlines, it's like hotels and motels. They have this concept called yield management. So they want to know how much it's going to cost to fly from Cleveland to San Francisco, what each seat can be charged at, and it keeps changing all the time based on how the plane is being filled with different kinds of payers, right? So the other issues is that we then have, if we've got to push productivity, we have less time for documentation, we have less time for counseling and advising parents and families and caregivers, we have less time for grand rounds kind of activities or team meetings, all right? So this is what I think of the downside. These are inconvenience stores. The products are out of reach. I think the images help. you can tell me at some point if they do or don't. So now we're going to talk about improving access to care. So last week was advocacy, trying to make sure that our services are on the table, not on the menu, or at the table, not on the menu. And then we've just finished talking about how services are paid for. Now, what are the things that we need to do to make sure that people who need our services get them, right? So reimbursement and funding issues are without doubt the #1 problem in terms of people getting our services. #1. So we spend a lot of energy, whether it's at Asher, whether it's OSHLA, whether it's inside an agency, spending a lot of energy, corporate energy, to make sure our services are covered. The second issue is that people still don't quite get the impact of a communication disorder on someone's life, unless they've seen it. And last Friday I was interviewing some of the candidates for the incoming class, and my standard question to all of them was, why are you getting into speech path? You know, there's so many options out there. Why are you choosing this profession? And, you know, what I was trying to get at is, do they have a personal link or experience with someone or themselves who has a communication disorder? So one of the candidates had been in speech path services for 2 years because of some issues, and she really got it in terms of why she was wanting to be in our profession. It's really an important issue. So the public doesn't get it. And part of our job, all of us, is to educate the public whenever we have a chance. And then the other thing that's out there is that in certain parts of the country, there's a real shortage of speech language pathologists. And in certain parts of Ohio, there's a real shortage. But I was doing some stuff for Asher a few years ago, and I was doing this Medicaid thing, chairing this Medicaid committee, and I get a call from a woman, a speech pathologist in eastern Montana, who's in hysterics because there's an aide out there in eastern Montana who's putting herself forward as a speech language pathologist, when in fact she's just a speech aide. She doesn't have the preparation, but Montana is first of all this ginormous state. You know, it could be its own country. And at the same time, and I've gone through Montana twice, it's boring. boring, except the western end, where the Rockies are. But anyway, the point is that she was in a panic because this lady's out there promoting herself as a speech language pathologist when she didn't have the credentials, didn't have the training, didn't have the experience. And so people are out there, they think, oh, I'm seeing Miss Cranmore, she's a speech pathologist and she's working my little Jeremy and nothing's happening. Yeah, I can imagine. So, you know, you have to start calling up the Montana Department of Ed and say, hey, you got a freewheeler out there in eastern Montana, what's going on? So you've got to understand what the impact is. You've got to make sure that we have the right number. And in Ohio, I think still we graduate 150 to 160. And now with Baldwin Wallace, it's going to be another addition of students. So we're getting close to 200 speech language pathologists graduating in Ohio a year. And we also have this churn, it's called turnover. People are aging out, retiring, and taking care of grandkids. So you need a sound rationale for our services. Why are our services so important? So there is this growing need out there. We have an older population in general. We have the age wave, as it's called, moving into retirement, 75 million people. And many of them have not been out there at the gym and doing whatever, so they're getting strokes and they're having other issues that lead to communication disorders. So we have a growing need for our services. Older folks also have, especially some who went to concerts and, you know, did stuff like that, who have depressed hearing as a result. Society is an information-based society, so everyone needs to have effective communication abilities. People who don't have effective communication abilities don't get jobs. Right? End of story. If you can't tell your story, you're not in it. Increased demand for appropriate reading abilities. So we're working with an organization in Cleveland, and what they do is they help companies find employees because it's a high-tech manufacturing company. They use very sophisticated computer-guided machines that are very expensive to make stuff, right? The number one problem they have is that when they're bringing in all these interviewees for jobs, the interviewees, 40% of them can't read the manuals, don't understand what they're reading. All right? So that's a whole other story. But we need folks with good reading abilities, and speech language goes right to that issue. Costs to society of communication disorders are left untreated. So in a ton of grants that we've submitted, we have all sorts of really solid data, and important because it's done by others, not speech language pathologists, but it's done by physicians especially. And they can put a number on what it costs to not provide speech language services, all right? So, big issue. So we need constantly, that goes back to last week, constantly working to protect or increase the coverage and reimbursement for our services. We need to establish contracts with these managed care entities or these HMOs. Mostly we deal with the managed care companies. HMOs are really, really, really tight in terms of their money. One thing that you'll need to do if you get to this level is you have to identify what are the 5 top reasons that we're getting claims denied. What's the top 5? And then you look at those and you create actions plans to address each problem. Reversing denials, I've talked a bit about that. Good understanding of coding, ICD-10 and CPT. Now on your handout, I don't know how I missed this, but your handout says ICD-9, and I was checking it out yesterday and noticed that I had missed that change. So it should be ICD-10. We're in a new international coding system. Another way to improve access is to create funding alternatives. All right, and so we need to find ways to support the daily operations of the organization, the hospital, the Cleveland Hearing and Speech Center, the whatever. We need grants for special projects, whether they're research or new programs that we're launching. So many years ago, Regional Infant Hearing Program in 2001 was something that we got a request for proposal from Ohio Department of Health, and myself and another person read through this proposal and said, whoa, we ought to be doing this. That's for sure, you know. So we sped down to Columbus to sit in on the RFP meetings, got all the papers, submitted the proposal, and that we get money from the state, about $160,000, $162,000 a year to support part of our Regional Infant Hearing Program expenses, which are around $230,000. So that distance, we need donors and we need other folks in the community to help us with. But whether they're models for telemedicine, FIND is a thing we did with the School of Nursing to help people who are deaf get the kind of care they need. All right, people who are deaf have a terrible time getting health care. Doctors won't see them. I'm not paying for that interpreter. Are you kidding me? Why do they need an interpreter? We'll just pass notes, or maybe mom can tell me what the problems are. All right, so we were in a situation last year where a woman in her 60s was dying of cancer, being treated at a local hospital. The woman was deaf. The hospital wanted her mom, who had to be in her 80s, to be the interpreter. We said, no, 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 no. And what we'll do, going back to advocacy, is we'll call the U.S. Department of Justice, Civil Rights Department, right here in Cleveland, Steve Dettelbach, and we'll talk to Mr. Dettelbach, and we'll say, hey, could you give them a call and tell them to do what they need to do for this patient? So, all right. Planned giving is another thing. Planned giving means, you know, when you're getting older, you guys are too young, you write out your will and you put in what you're going to give your thousands of pennies to, and you give it to Cleveland Hearing and Speech Center. And then endowments are sort of like savings accounts that organizations have. People make gifts, and when they say, I want my gift to go to this, you have to put it in a special fund, and it creates an endowment, whether it's a chair for a department or for services, right? So, support personnel, we call these folks the care extenders. So care extenders, people who are outside speech language pathology, but can also do stuff when provided the right kind of training and guidance. So first of all, our support personnel, that is aides. So we have speech-language pathology aides in some states. We have hearing, not aides, but hearing technicians, I guess. And what they're meant to do is, like if you go to the, get an ophthalmology exam, right? So you won't see the ophthalmologist first. You'll see some technician who'll do the funny things with the goofy glasses machine, and then there'll be someone to do the intake, and then someone with the goofy glasses machine, and then finally you will get to see the ophthalmologist, the MD. So like here, we're adopting that model now. So we have a young lady who has been working for us for many years. She understands Cleveland Hearing and Speech Center. She especially understands our audiology program. So Kelly is doing that sort of preliminary work. And that frees up the doctoral level audiologist to do doctoral level audiology work, not guide the person to the waiting room or the audiology booth, not help them fill out the forms. No, 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 you don't need an AUD to do that. So it's a misuse of personnel. Family members and other caregivers, that's always a challenge. It can be really difficult. It really depends on the family members and the caregivers. Some don't want to do it. I'm paying you to do that. You know, I don't want to be my kid's stuttering therapist. Trained volunteers is another way. So many years ago when I was working in schools, I was working in so many different schools around this county that I was able to persuade 2 districts in particular to hire aides that would sit with me in treatment of kids, and then I would give them a little plan, and you do this until I come back next Tuesday. So a trained volunteer. And then, of course, you guys. You know, so you'll be downstairs if you're not already. Oh, some of you are. And so that's another way we have of improving access, extending care to people who need our services. Some other ones are technologically based. So, you know, without a doubt, the internet has been just a godsend for all of us, but especially for people with communication problems. But we can use telemedicine, telepractice, whatever you want to call it, and it allows me to see a person down in Chillicothe who's got fluency problems, you know? So now Ash has got Special Interest Group 18 that looks at telepractice and how should telepractice be done so that it's effective, it gets results, and basically that. So the issues are licensure. I can't, even though I have a couple licenses, I can't do telepractice in Michigan. I'd have to have a license in Michigan. I can't do it in Oklahoma, you know. So that's a real problem. And then the other thing is the HICS, the health insurance companies, they consider it experimental. Where's the evidence that this works? And when did we do that study with the community health centers? 10 years ago? Whatever. It was a while ago. So we had a study that Kay and Bridget Whitford and our staff did with these community health centers. And we were able to show that using telepractice technology, we could get the same kind of results for screening as doing it live, pretty much, right? Correct. So, and then we call those communication kiosks. Physicians in the public still have a limited understanding. I think I've talked about that a little bit. At every opportunity, take the chance to educate people about what you do. So I'm flying back from San Francisco where my in-laws live, and I'm on this plane, and this guy sitting next to me said, "What do you do for work?" "Well, I'm a speech pathologist." "Oh, really? Did you go to school for that?" Yeah, a little bit. Yeah. You know? So I told him nicely what the preparation is that speech-language pathologists need, and he's going, "Oh my God, really? That's kind of impressive." Who we work with, what kind of populations we work with, all right? They're kind of missing stuff. So take every opportunity you have and develop your elevator speech. Adjustments in employment and other environments. So more and more hospitals and Cleveland Hearing and Speech Center type organizations are creating flex time schedules. We recognize that the bulk of our employees are women primarily, and primarily younger women who are getting married, starting families. So we have to adjust to the realities there. non-traditional schedules like, well, I can't work Monday through Friday because I do this, but on weekends I could be available. So that extends our care and improves access. Satellite offices. We've added an office in Broadview Heights, but now the board of directors here is looking at offices further east and maybe farther east and out west. All right, to again improve access. We know that people will travel about 30 minutes max, unless it's a special problem for care. Interagency collaboration, so we might work with achievement centers, we might work with United Cerebral Palsy, other entities in Cleveland, Center for Families and Children, and then home visits. So the issue there is how much does a home visit cost and is it effective? So I'm going to wrap up here with what our current ethical dilemma is as a profession. And it really is this. We want to provide quality services. You know, I've rarely run into a goofball who just wasn't interested in doing a good job. But we need to increase the emphasis on delivering a specified number of billable units or the number of people in your caseload. And so how do you maintain quality? That's really the question. How do you maintain quality if you're seeing 110 kids a week? How do you maintain quality if you have to do 35 patient visits a week? It's really difficult to do that. Where do you get the preparation time? Where do you get the documentation time? Where do you get the chance to meet with the doctor or the parents or whoever? So it's a real challenge in our field. And it's not that administrators or department directors aren't aware of it. We really are, and trying to figure out how do you balance this all. So you have to start somewhere. One, and this one I really like. There had to be a second to the last of the Mohicans. You know, if he's the last of the Mohican, I must be second to the last. Okay, so with all of that, any questions from our triad?
I guess I have a question, kind of going back to your last slide.
Yeah.
Like, how do we build value or the perception of value into what we do with such limited resources?
So here's things that come to mind immediately. I think one of the important things is improvement is incremental. Sometimes it's quantum, as they say, but generally it's incremental. All right? So what I used to do when I was a practicing clinician is I always had a tape recorder with me, and I'd be recording. You know, they were these little plastic things, and they had spinny, anyway. So I would record all my sessions. You know, and I might not record the whole 50 minutes, but I'd record 10 minutes or whatever. And I was trying to show mom and dad or one of the BVR counselors, here's Rachel when she started with me in her speech fluency problem in June of whatever. Here she is in August. And I had it, you know. So it's hard for the parent, and it was good for the clinicians too, because we forget how, you know, far behind the child or adult was. But if you have this audio, now we have digital capacity with video and audio. You know, you got a microchip that's this big, and how many, 128 gigs on it. It's nuts, you know? So one way is to really show dramatically through a video or an audio how the person has improved. We did a thing that really, I think, blew our board of directors away a few years ago. We had a young kid, and we were working with Josh. We started with him when he was about 4. He's a spectrum kid, all right, really severe. But mom and dad were terrific. At least mom was always at the sessions. But we would video Josh periodically, all right? So we ended up seeing Josh for 7 years, and we were able to show mom and dad and others, but especially my board of directors, here's Josh at age 4. Here's Josh at age 11. Look at that difference. Now, it took 7 years, not getting around that, but if we hadn't done anything, he'd still be doing this. You know, forget it. So, to me, the most powerful way to demonstrate value is to show what you've done. And if you can do it with audio, great. If you can do it audio, video, even better. You know, Then, of course, there's test scores and all that stuff that, when you're administering a self or whatever it is you're administering, you show, well, he was here when we first started, and now he's here on this test. So that's another way to give value. What would you think? Because really, once you start practicing, you're going to have to demonstrate value. You may have to demonstrate it to mom and dad or to the husband or the wife or whoever. You may have to demonstrate it to your department head. So we had a situation up at in Detroit at the medical center there, Henri Ford, and they wanted to drop all swallowing services. So what the director did, who was my predecessor here, is he mobilized a group of physicians and himself and a couple other clinicians, and he was able to demonstrate to the administrators, if you cut swallowing, here's going to be the impact on the hospital's bottom line. It's going to be over $1.5 million. Really? Yes, and this is why. Dun, 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 dun. All right? So demonstrating value that's a terrific question, and it's one that, as a profession, we have to do a better job demonstrating. Okay?
I do have another question.
Okay.
In the legislative arena,
Yeah.
how do we get from the intent of our laws to the implementation, proper implementation?
Yeah, that's another good question. So laws are written in a very general way. All right, when a bill is introduced in the General Assembly or in the Congress, it's introduced in a very general way. And then if it passes the process, how a bill is passed, go look at that little civics lesson, then it's turned over to the executive branch. So the legislative branch writes the laws. The executive branch puts in the details, the nitty-gritty stuff. That's why we have CMS and those kinds of entities, Department of Ed, whoever. And they put in, and that's, it's best if we can have input at the bill level. The earlier you can get involved in the process, the better. So if you're there while they're writing the bill and they see that speech language pathology and audiology are essential services, essential basic services, fantastic. Because then you don't have to fight that battle in the executive branch. All right? And then that's where then the judicial branch comes in, when people don't enforce or don't do what they're supposed to do. So that's when school districts get sued or hospitals get sued. When I talked to this administrator, not the case about the daughter and the mom, but it was another deafness issue in another town farther south. I knew this guy from different meetings in United Way, and I said, Joe, you're juggling dynamite. You're juggling lit dynamite. It's just pay the $95 and quit messing around with regard to this person needing a qualified interpreter. Not their daughter, not their 5-year-old son, Anyway, other questions? Yes.
So these issues that present themselves,
Yeah.
Is this a result of growing pains in a relatively young field, or are these issues that other healthcare professionals are also encountering?
Yes.
Okay.
Yes, yes, and yes. So the issue is this, we had a visiting professor here from Germany 5 years ago or something, and I went to lunch with her, and she thought our whole system of healthcare providing and paying for was comical. So in Germany, if you have a speech-language pathology need, you go to see the logopede and you get your speech therapy stuff, and then the government pays for it. Here, of course, that's not the case. So it's a problem in all disciplines, not just speech-language pathology or audiology. PT, OT, neurosurgery. Neurosurgery is they're the rocket scientists of medical care. And so even neurosurgeons have to call the insurance company, or their staff do, and say, what are you doing here? This guy's got this particular kind of tumor, and if he doesn't get it removed, he's going to die. I don't get your problem, So everyone is developing these very powerful advocacy groups. But you've got the other side who are representing the insurance companies and don't want, they want maximum value for their shareholders. All right, they want maximum results for their shareholders. It's a tremendous tension. It's being played out right now on TV every night. We're seeing it. Other questions? Yes.
You said in the process of helping out the woman who was having her mother
Yes.
being asked
Right.
to interpret for her, that you contacted ASHA and they were a part of the
No, we
process?
contacted
or-
the Office of Civil Rights of the Department of Justice.
Okay, but for the binders of information
Oh,
that
that
you put
was,
together.
yeah,
that-
ASHA helped us. We had to gather information through our state directors group to show this insurance company in Cincinnati that they needed to cover our services. So we called ASHA. ASHA provided us a ton of stuff. We had a ton of stuff specific to Ohio, and we sent it to Cincinnati. All right?
So there is, you can just call
ASHA is
Great
huge,
resource.
and I think right now ASHA has 140 employees. It has a annual budget about 30 million. We have 165,000 members. We're finally a voting block of consequence, and they will bend over backwards to help you answer an insurance or an advocacy question or whatever. Just go to the ASHA website and tootle around a little bit. Hop around the site. It's an excellent site. Anything else? Ms. McNeil? All right, well, thank you very much. We went over a little bit. There's no extra charge. All right, thank you.
Thank you.